It is 10:01 a.m. And I think looks like we have
I don't want this.
pretty close to enough people here for to start the roll call. So agenda item number 1, we will do a roll call of members and establish quorum. Garrett, can I get you to take over and begin the roll call of members of the committee?
Absolutely. Is Jessica Barlow here?
Jessica Barlow here.
Okay. Is Brittany Collins Jefferson here? Is Lanetra Grady here? Okay, is Ryan Gustafson?
Good morning, Lanetra's here.
Lanetra's here. Awesome, thank you. Is Ryan Gustafson here? Is Dr. Kamyar here?
Present.
Is Carissa Loper here? Catherine Loudon. Elise Monroy. Darcy Patterson.
Present.
Jamie Ross. Pauline Sala.
Present.
David Sanchez.
Present.
Ariana Saunders. Cornelius Sheehan.
Present.
Laura Sherwood. Malika Toston.
Malika Toston, present.
Dr. Carla Wagner.
Present.
And Quinny Winbush.
Present.
That concludes roll call, and we have established quorum.
Thank you, Garrett. I'd just like to note that I see Ryan Gustafson here. Ryan, are you here?
Yes, I am present.
Thank you. It looks like that's the only person that I can see that was called, but maybe got in a minute or two late. We are going to move forward with the agenda now. We're going to start with agenda item number 2, which is public comment number 1. Public comment will be taken during this agenda item regarding any item appearing on the agenda. To provide public comment telephonically, dial 775-321-6111. When prompted to provide the meeting ID, enter 137-487-683#. Just like you all to keep in mind, to be considerate of others who may also wish to provide public comment, please avoid repetition and limit your comments to no more than 3 minutes. Again, no action may be taken on a matter discussed under this item until the matter is included on an agenda as an item to which action may be taken. Do we have anybody for public comment? Garrett, do you see anyone?
I do not.
Let's give it another second, just so we provide the opportunity. And I know that switching back and forth between teams and Zoom can be challenging to navigate. So we'll give folks a second to see if there's anyone available or interested in speaking as part of agenda item number 2, public comment number 1. Garrett, I don't see anybody speaking up or raising their hand. Can you confirm?
I do not see anyone that wants to make a public comment.
All right. Thank you, Garrett. At this time, we're going to move forward to agenda item number 3, which is review and approve the minutes from our June 13th meeting. These minutes were posted on our webpage and also sent via email to the committee members. Do any of the committee members have any questions or concerns regarding our minutes from our last meeting? If not, do we have a motion to approve the minutes?
This is Pauline. I'll move to approve our minutes from the June 13th, 2023 meeting.
Thank you, Pauline. In order to move forward, I'll need a second on the motion, and then I will begin the vote to approve the minutes.
This is Darcy Patterson. I'll second.
Thank you, Darcy. At this time, we will take a vote to approve the minutes from our last ACRN meeting. All in favor of approving the minutes, please say aye.
Aye. Aye.
To me, it sounded like I had 2 folks that were in favor of approving. If I missed anybody, please speak now. All right, I'm gonna go to any in favor of not approving the minutes, please say nay. I did not get any responses on the nay side. Going to move to any abstentions to approve the minutes from our last meeting. Now's your chance. Let us know by saying that you're going to abstain, or I got Dr. Wagner's hand up for abstain, I believe.
Yes, I wasn't here.
Cornelia Shan abstaining.
Thank you, Cornelius. Anyone else? Well, that looks like that's what we got for approving the minutes. I'm not sure what that looks like from administration side, but it seemed to me like we had 2 to approve, 0 for nay, and 2 abstentions. I'm not sure if that approves them or not. State team, do we have an answer on that?
You would have to have the quorum of the members speak up and state whether or not they approve, didn't, or not approve, or abstain.
Thank you, Hannah. I appreciate that. It seemed like we lost a couple of people during that vote. So anybody that did not participate in the vote that is a sitting committee member, we will need to hear from you one way or the other, whether it's for, against, or abstention.
This is Ryan Gustafson. Sorry, my microphone has been acting up. Yes, approved minutes.
Thank you, Ryan.
Jessica Barlow. I was also dropped from the meeting, and I vote yes to approve the minutes.
Thank you, Jessica. And Dr. Camero, did I hear you in there as well?
Correct. Approved. Thank you.
Thank you. Just check my list here. Oh, we did get, Jamie Ross is now in attendance. Jamie, are you here?
Yes, I'm here. I will have to abstain as I was not at the last meeting.
Thank you, Jamie. So at this time, it looks like we have 5 or 6 fours. No one against and 2 abstentions. Sounds to me like we're a little closer to approving the minutes, but can I get confirmation from the state team that we are good to move forward? Or do we need to hear, is someone missing? 3 abstentions, sorry about that.
Chair Sanchez, you have my approval of the minutes, correct?
Yes, thank you, Pauline. Well, it sounds to me like we have the votes needed to approve the minutes from our last meeting. If I am wrong, okay, good. Looks like the minutes have been approved for the state team after our vote. And we will move forward in the agenda. At this time, we'll move to agenda item number 4, where we will get an update from Don Yohey regarding the Fund for Resilient Nevada and the settlement funds and program funding. Don?
Thank you, Chair and members of the committee. I'll just wait for the presentation to come up real quick. This is a presentation that we also gave to the Surge group a couple of weeks ago, so we wanted to make sure that you guys were aware as well. Next slide, Garrett. Oh, sorry. My name is Dawn Yohey. I'm a clinical program planner with the Department of Health and Human Services, assisting with the oversight of the Fund for Resilient Nevada, which is the state's portion of the opioid settlement. So the first couple of slides is just a little bit of background. As you guys know, Nevada revised statutes 433.712 through 433.744 established the Fund for Resilient Nevada in 2021. One of the Department of Health and Human Services responsibilities is the development of a statewide needs assessment, as well as a statewide plan to drive funding allocations, which you guys assisted with. The needs assessment was completed in July of 2022, and the statewide plan was finalized in December. We went ahead and linked the needs assessment and plan here. NRS also created the advisory committee for Resilient Nevada to identify and prioritize recommendations to the director's office by June 30th, every even numbered year. So we went ahead and linked your report. Next slide. A report regarding findings or recommendations and expenditures is due on or before January 31st of each year to the following entities. That was completed in January of this year. So we went ahead and linked this as well. Next slide. Before we were able to do any sort of allocation of funding, we did have to do some opioid fund mapping. These are all very high level dollars that are going towards opioid funding. The substance abuse block grant is not necessarily specific to opioid funding, but we wanted to put it in here because some of their dollars are used for it. So they get about $20 million per year for 2 years. That is block grant funding, so typically comes in. The state opioid response grant gets a little over $16 million per year. It's every 2 years with the option of no cost extensions. The comprehensive opioid stimulant and substance use program, the COSUP, was a little over $5 million in total for 2 years. The overdose data to action state portion that they just applied for was about $2.6 million per year for 5 years. We may have a presentation by them today. They did apply for the overdose data to action, but they were not able to get some of the additional options that they had applied for. So we'll hear from them. The overdose data to action local levels averages around $2.3 million per year for 5 years. And then some expenditures from DHCFP, which is our Nevada Medicaid. These are expenditures from July 1, 2021 through June 30th of 2022. As you can see, we do have the fee-for-service opioid use disorder expenditures, as well as the substance use disorder expenditures, and then we went ahead and added the MCO expenditures as well. Next slide. The statewide plan goals. Goal 1 was to ensure local programs have the capacity to implement recommendations effectively and sustainably. Goal 2 is to prevent the misuse of opioids. Goal 3, reduce harm related to opioid use. Goal 4 is to provide behavioral health treatment. Goal 5, implement recovery communities across Nevada. Goal 6 is to provide opioid prevention and treatment consistently across the criminal justice and public safety systems. And then goal 7, provide high quality and robust data and accessible timely reporting. As you guys remember, all of those recommendations were turned into objective strategies as well as actionable items and placed into these goals. And then also as a reminder, the budget for the Fund for Resilient Nevada is over an 18-year period. So the use of funds has been approved during the biennium, the legislative session, as well as through interim finance committee. Next slide. I know this is a very small table. I'm sorry, the words are so small, but these are current awards that are either in progress or already executed. We did do a NOFO in March, and so we were able to pick 4 treatment providers: Living Free Health and Wellness, an expansion of the Washoe County Department of Alternative Sentencing, an expansion of the Empower program for Roseman, as well as Carson City Community Counseling Center's new residential treatment facility. And then the FY24 awards to some of the entities. Down at the bottom, you'll see goal 1, goal 2, goal 3, goal 4. That is because those are some items going to August IFC next week to pull additional dollars out of our reserve. And then, so you'll have the awardee, the amount obligated, some notes on what the dollars are going to be used for, the location, if it's, rural, if it's Washoe, Clark, statewide, and then as well as how it links back to the state plan goal. Next slide. As part of the statutes, we are required to provide technical assistance to any county, region, or tribe that is requesting technical assistance while they are developing their needs assessments and plans if they would like a portion of the state funds. So we are contracting with Mercer still. They're the ones who helped us with our needs assessment and plan to provide technical assistance to the following counties. These are the ones that have reached out already. Carson City, Churchill, Elko, Humboldt, as well as Nye. We are anticipating the following counties will also need assistance and will be reaching out as Lander, Pershing, White Pine, Eureka, and Lincoln. Next slide. The following counties have already finished their needs assessments and are not requesting technical assistance. So Douglas, Lyon, and Washoe County. As well, Story County, at the time I created this, it was complete, but it had not been approved by their commission yet. Mineral reported that they are almost done. Esmeralda also reported that they may incorporate into NICE. And then Clark County has reported to us that they do have many needs assessments, and so I think they were going to be working off of some of those, so they have not requested any sort of technical assistance at this time. Next slide. For the One Nevada agreement, there is a reporting requirement. So they are required to report on a calendar year. So we got 20 responses for the calendar year of 2022. So here are the entities that did respond to a report based on the One Nevada agreement. Highlighted in yellow are individuals who have reported intent to use the funds. of how they may use the funds, and then highlighted in green are entities who have already started using some of their settlement dollars. And then everybody else who's highlighted, they reported, but they reported that they have not used any of the funds and they don't have an intention at this time of what they are going to be doing with their funds. And then the final page, Garrett, next page. We just went ahead and wrote down the entities that reported use or intent. This is how they were saying that they were going to be spending their money or have used their money. So the city of Henderson, they did their fentanyl awareness campaign towards youth, as well as they're putting some money aside for some mobile teams. City of Las Vegas says that none are spent yet, but they are doing like criminal justice, adult and youth, and capital projects. And so this report just hopefully will be a little bit more robust next year as people have started identifying how they're going to be using dollars. So any questions?
This is Pauline. If we, on slide 9 with the jurisdictions that have, I think it was slide 9. So Humboldt County, I thought we did a report, we just hadn't spent any. Because our needs assessment is being finalized on Thursday, and then we'll take it to the commission. But did you say the ones that are highlighted yellow reported? They just hadn't spent
No.
anything out?
Everybody on this list has reported.
Okay.
I need to go back and figure out how many people actually signed the One Nevada agreement, but everybody on this list reported. It's the highlighted yellow is that they report an actual intent of use of the funds. And then the green, they already started using the dollars.
Okay. Thank you.
You're welcome.
Dawn, it's Carla Wagner. Can we just see the slide right before this again? I just didn't get to look at it long enough. Thank you.
Right before?
No, that one. This one.
Oh, this one. Okay. Mm-hmm. Yeah, and at the time we got this report, this is Dawn Yohey. At the time we got this report, it's for calendar year of 2022. So there may be an intention of the use of funds from many other places at this point. So
can you tell us what capital projects are under City of Las Vegas? What is a capital project?
I'm not sure at this point. I would have to go back and specifically ask them. Those were just, I'm assuming it's building projects, but I'll have to go back and ask, and I can get a little bit more information if you'd like.
All right, Dawn, thank you for your presentation. Do we have anybody else that has a question for Dawn? Any comments from the committee?
Thank you, everybody.
Thank you, Dawn. At this time, we will move forward to agenda item number 5, which is Fund for Resilient Nevada presentation on quality assurance evaluation reporting guidelines. And this will be from Vanessa Diaz, quality assurance specialist with the Director's Office, Department of Health and Human Services. Vanessa?
Hi, everyone. I'll just wait for Garrett to put the slides up. But yes, my name is Vanessa, and I'm the Quality Assurance Specialist for Fund for Resilient Nevada. And today I just wanted to share with you all our current and ongoing reporting and evaluation guidelines. Some of the topics we will discuss are the definition and the utility of an evaluation plan, the guidelines that have shaped our internal evaluation, some common questions we ask, the methodology we use, and some of the documents that our programs are required to submit on a monthly basis for ongoing internal evaluation. So what is an evaluation plan? It is a documented framework that outlines the strategies, methods, and procedures for assessing program effectiveness. So conducting an evaluation plan is essential to determine if our programs are meeting the goals. So an evaluation plan is one of the key documents that guides the evaluation process from beginning to end. It is a roadmap and it shows how effective each program is. And I think it's important to note that it is a living document. So any changes and updates are made. We're consistently looking at our evaluation plans and how we evaluate each and one of our programs as often as needed. Next slide. Utility. So 7 reasons to have an evaluation plan. I wanted to let you guys know why we emphasize evaluating each one of our programs. So the most common and most important one is assessment. It's a framework for understanding effectiveness and creating evaluation reports. The next reason is for decision-making purposes. An evaluation plan is valuable because if it helps you or our programs do what they need to do better. So I think that's super important to always be on top of any issues or any things that may occur and be ahead of the game. So we believe in the model of giving continuous feedback to our programs so that we can make decisions along the way on how we can be improving the programs within the award period cycle that we are in. And as you know, most of our awards go on for 1 year. So at that end of the year, we look and evaluate the programs to see are we going to fund them again, etc. Accountability. This is where the evaluation team and the evaluator can hold the program accountable for following or not following the plan, or in our case, the scopes of work that lists the goals and objectives and dates of when things are stated should be accomplished by. We can go to our programs and say, hey, by this date, you said you would have this done. How is it coming along? Do you need any technical assistance, any training, any help to accomplish this goal? So this piece helps us add accountability and transparency. An evaluation plan is also great for engagement with any stakeholders and for sustainability because it demonstrates a clear commitment to outcomes. Lastly, replication is another reason why we create evaluation plans. An evaluation plan provides for us a very clear opportunity to weed out the stuff that isn't helping us so that we can replace that with practices and procedures that will help us. Next slide. Pew guidelines. So I just put this in here because I wanted to show you all that we are using specifically for our treatment providers, the Pew Charitable Trust guidelines that were researched, and we've made this a foundational component of our evaluation process, specifically for our treatment providers. This is known as a cascade of care, and it is a set of core metrics used to track relevant data and provide a comprehensive picture of care for opioid use disorder from diagnosis to recovery. So it tracks all of that. This is specific to our treatment providers, and in our current award cycle, we are funding, as Dawn has shown in who we're funding in our previous presentation, we are funding some treatment providers. So I wanted to let you guys know that we do have specific guidelines according to the Pew Charitable Trusts. Next slide, please. Thank you. Evaluation questions. So the purpose of having these questions are to specifically identify the knowledge, attitudes, beliefs, and behaviors that will be impacted by the programs we fund. Some of the important questions we ask are: how will programs recipients be impacted? How will the organization be impacted? What are the short, medium, and long-term goals? The triangle on the side does a good job at summarizing the basic areas of curiosity that we may have in measuring the impact our programs are having. So this is the purpose, and we may be asking people's reactions to something, what they've learned, how has the behavior changed, and any results and benefits coming from that. Next slide, please. Methodology. Now, this is probably one of the most important pieces here. So this is where we get into the specifics of talking about validity, reliability, qualitative and quantitative data. So methodology describes in as much detail as possible the approach and activities that will be used to better understand the impact of the program. So we are going to list everything that we believe our programs will be doing according to their scope of work. And then we measure and determine if they have been successful in doing those activities and objectives. So when programs submit a scope of work, they're listing their goals, their objectives, and the activities assigned to each goal. So on a month-to-month basis, we are going through and making sure and determining if they have been successful and are on the track to success. So there's a longer list of questions, and some of these important questions include, like, what types of data will we be collecting? Is it going to be surveys, interviews, group listening, any sampling procedures? How will the data be analyzed? What are the protocols the program is taking to make sure there's anonymity and confidentiality, etc. And the picture on the side just shows us here 2 different evaluations. So process evaluation covers the who, what, when, where, and it includes qualitative and quantitative data. Then when we're looking at outcome evaluations, we look at specifics like changes, effects, and impacts of the program. Also includes qualitative and quantitative data. Next slide, please. Ongoing program evaluation. So this is where I'm going to show you so I will take you through some of the documents we require from our providers on a monthly basis. So some of these include project status reports. These are monthly documents submitted by each program. Monthly provider calls. We set up calls each month with our providers to make sure we're able to discuss what was said in the project status reports and anything else. Our data collection that providers are also required to submit on a monthly basis, specifically treatment providers. Without their submission of these documents, they do not receive reimbursement. Site visits, these are things that we schedule 6 months to 1 year after the award is granted, where we're able to go to the place, go to the program, and see in person how everything is functioning. So for monthly provider calls, they occur after the 10th of every month. And that's because on the 10th, RFRs, or requests for reimbursements, are submitted. That's when data is submitted. So we like to schedule our calls after that. And yeah, next slide, please. So this is our first document, the project status reports. So this first page here just shows you a quick summary of how we organize each provider. We make sure the project name is there, the funding amount, who the project manager is, and the total spent up until this month. In the summary, we ask for any highlights in the overall status. So things can include like delays in some client referrals, but minimal. So we want to know some things that they have encountered this month specifically. And again, this document is filled out on a month-to-month basis. Next slide, please. Now here is where we get into our scope of work progress. So I created this document with the intention of making sure that each goal is easily readable and identifiable to anybody who wants to see these documents. So if you see this document, you're able to know what each program is doing. So goal 1 will be we fill out the goals on our end. And let's say a goal is to gain housing for a residential program. So we will ask for updates each month on how that is going. What is the progress? Are you on track, or are you a little behind? And on the notes section, we ask for specifics. So anything, here's where I want to know, like, how many clients are you serving? Is there any issues? Did you add any new members, etc.? So just specifics about things, but we list each goal that the provider has in their scope of work. And again, this document is meant to be just a snapshot, a quick snapshot, so that we can send this out to you or show you guys, if you guys ever request, show you all what our providers are doing on a month-to-month basis. In the concerns section, I'm able to list here. I want providers to be able to list how many concerns do they have a month. What does it pertain to? Are there roadblocks? Do you see any community roadblocks, any trends that you're seeing in the community? And is the status ongoing? Is it resolved? And what is your solution? So sometimes our providers will ask for help with data collection. So maybe that is a roadblock. They don't necessarily know how to submit the data that we are requesting. So the solution would be to request technical assistance training from FRN, from our team. This can also include any budget modifications like, you know what, we're actually seeing that we may be needing a little bit more funding in this area than we anticipated. Next, we ask for milestones, highlights, or any community trends as well here. Milestones are important. Highlights are important. We want to make sure that we're highlighting the incredible stories that are happening in our programs, again, so that we're able to have a snapshot of what is going on with each one of our programs and discuss it with anyone. Lastly, supports needed. So this is where the program gets to ask us for any help. Maybe they need help with us contacting somebody. We want to take an active effort, an active participation with each one of our programs to make sure on a month-to-month basis, if they have any hurdles or obstacles, we're able to come alongside them and help them overcome these issues. Next slide, please. All right, this is our monthly provider call. And this is where we discuss any questions and concerns we may have about the project status reports. So this happens after they submit the project status reports. This is just a template that our internal team uses. So the provider doesn't necessarily see this, but our team does. And we're showing you this so that you know that each one of our calls are structured, and we find it important to discuss things that come up even in topics covering requests for reimbursements. So we receive purchase reports from each one of our providers. It's a requirement for each submission, and we look at each thing that they're asking for reimbursement for. So we ask questions like, are these costs allowable? If an unallowable cost were to come up, this is where we discuss it in our monthly provider calls. So we talk about the awesome things, the good things, the important things, but also the hard things. And I think it's important to continuously evaluate the things that they are asking for reimbursement for on a monthly basis. We also discuss any hurdles and solutions, any updates. So basically, this is just more of an in-depth conversation that we have with our providers monthly. And we do this so that we build rapport and that we are also connected to what they're doing. Next slide, please. Data collection. So the purpose of data collection is to identify one, we will identify who's tasked with data collection and what that data collection involves. It varies across different providers. So we're funding treatment providers. We're funding different things that don't necessarily require monthly data, but may require annual data. So it depends. That's why I wanted to make sure I put that in there, that it will vary. So we will be collecting data using evidence-based and standardized surveys, such as TEDS and the National Outcome Measure Survey. Treatment providers are required to submit data monthly, and other programs are required to submit annually for reimbursement. So I just wanted to talk to you slightly a little bit more of what our data looks like. Again, it's going to be TEDS data and some of the national outcome measures, and it will be standardized into an Excel sheet. And some of the questions we want answered in regards to clients is always going to be great demographics, such as age, race, zip code, primary diagnosis, any co-occurring disorders that may be going on, what kind of treatment they're receiving, was there any additional referrals made? So these are some of the questions we cover. We need to be able to identify if we need to push services into a certain place or not, and identify any trends in order to take action. And everyone will be collecting some sort of data based on the type of provider. You can move on, Garrett. Thank you so much. This is probably one of my favorite slides here. I love this slide because it shows us the different stages programs go through and the types of evaluations that take place in each stage. Some of our providers will be in the new program stage. Some of them will be in the established program stages. So as you see here, we have program stage, questions asked, and the evaluation type. So before a program begins, which Dawn has linked in the previous presentation, we created a needs assessment, statewide plan, and some of the questions asked is what extent is being met, at what extent is the need being met, what can be done to address this need. Now for some of the programs that we're funding, as I mentioned, some will be under the new program and established program. So these are the evaluation types that we will need. We ask for process and implementation evaluations. We will definitely be receiving outcome evaluations, and mature programs are usually when we receive impact evaluations, but that's after several years of a program running. So I just wanted to give you a short table on that. Next slide, please. This expected outcomes tool. So we can have the best plan in the world, but if we don't have an action plan, it's not going to work. So this expected outcome tool just basically shows who is going to do what and how we are going to do these things. It shows the primary role of data and the kind of data we need and where we will get it. It answers things like who is going to analyze the data, who is going to gather the data, who is going to write the reports, provide the resources, and who will coordinate site visits, presentations, etc. And this is just a tool that we use to help keep things organized on who is going to do what so that we are consistently on track on evaluating our programs internally. As a note, this is our evaluation plans, and doing evaluations in each one of our programs is our internal responsibility. And we will be doing these evaluations and monitoring internally, but we will also be working with an outside evaluator to come in and make sure our programs are working as well, to make sure that we are providing efficacy and abatement. Also, I'd like to mention that it is a bit soon to identify if the projects we are currently funding are working or not, but within the next year, we will have a better idea and direction as we continuously evaluate on a month-to-month and annual basis. Thank you all. If you have any questions, please let me know.
Thank you, Vanessa. We appreciate you taking the time to bring your presentation to us, and it is very useful information. I'm glad to see what you guys are getting done and doing with your team. Do we have any questions or comments for Vanessa? I have Dr. Cameo.
Hey, Vanessa, Farzad Cameo here. Thanks so much. Not specific to this, but I just noticed it was like on one of the first couple slides about one of the metrics being number of prescribers, buprenorphine, who's prescribing, who's not. And I haven't thought about this before, but we probably need to reconsider those, given that really anyone with a DEA moving forward is going to be a buprenorphine capable prescriber, right? We don't have that designation anymore. So just if you can put that on the radar or appropriate radar, so we don't forget.
Thank you so much. I appreciate it.
Do I have any other questions or comments for Vanessa before we let her go? All right. Again, I want to thank you for showing up and giving us a presentation, Vanessa. Very appreciated and great information. At this time, I'm going to move forward with the meeting, and we will move to agenda item number 6, which is going to be a presentation on comprehensive opioid stimulant and substance use program by Dr. Kerns.
Thank you, Chair Sanchez. I want to take the opportunity to thank everyone for the ability to highlight the COSAP grant. As you'll note on here, when we originally applied for this grant, it was the COSAP, and many of you may remember it as COSAP, but because the program managers, Bureau of Justice Affairs, understood that language does matter, they did change it and update it to the Comprehensive Opioid Stimulant and Substance Use Program. So it's now COSAP instead of COSAP grant. Next slide, please. Now, as part of the COSAP grant application, we applied for the following allowable uses, and it was for a 3-year grant period. So we applied back in 2022 and 3 years going through 2025, but it was not approved, or it was awarded in December 21st of 2022. We were not given approval to start spending funding until August of 2022. So having said that, we were like almost a year behind on starting and not having the ability, not guaranteed a no cost extension, but everything anticipates that we will likely get a no cost extension so we can start continue with the 3-year grant period. But as you can see, the allowable uses, the first one was law enforcement and other first responder diversion programs. The ones specifically that we addressed within this grant were the most mobile outreach support, or some people say safety team, and then also the FAST team, which is the forensic assessment services triage teams. So the differentiation between those two, if you're not aware, is most is more of the pre-arrest and diversion. FAST is for people who are already incarcerated. So providing assistance to those individuals that are in the criminal justice system already. And as part of this, the second allowable uses was for the distribution of naloxone. I will say that traditionally the Attorney General's office isn't in the business of the distribution of naloxone, but this was a grant that we worked in collaboration with DHHS. And originally we were going to apply for that first allowable uses of the law enforcement and first responder diversion. But as opposed to having DHHS apply for a grant for the naloxone distribution and the drug take-back days, we agreed it was better to put all of those allowable uses into one, so we weren't competing against each other for the same grant funding. So we did have the support and collaboration of DHHS as we move forward for this grant. Next slide. As part of this, we do have subgrants. And those sub-grants, as you can see, are Partnership Carson City. And Partnership Carson City then has, as we call it, sub-subs under them. And the sub-subs under Partnership Carson City are Churchill Community Coalition, Partnership Douglas County, and then Healthy Communities Coalition. And the second is Community Chest. Third is NIE Community Coalitions. And then we have UNR and Social Entrepreneurs Incorporated, SCI. As you look at this, you can see as well which counties are covered. So Partnership Carson City does cover Carson City. Churchill is for Churchill County. Partnership Douglas County covers Douglas County. Healthy Communities Coalition is for Lyon County. And then Community Chest covers Story County. NIE Community Coalitions covered Nye and Lincoln counties. And then for UNR, it was to provide an evaluation. And for SEI, it was to provide SME, subject matter expert types of training. And I would highlight on this that, again, the Overdose Data to Action Grant had previously funded some of these activities, such as MOST and FAST teams, and also the evaluation. So we that funding had ended, so we picked up the MOST and FAST teams and then continued on with the evaluation component of the COSAP grant. Next slide, please. I would like to highlight, if you want to find out more in depth about MOST and FAST, if you go to this website, which I provided the link at the bottom, the Nevada Regional Behavioral Health Policy Boards, and you go to the resources. If you do the drop down menu on resources, it will take you to the Most and FAST, which will give you much more detailed information about what they're doing. One of the other deliverables that we're working on, again, off of the heels of the Overdose Data Action Grant, is putting together toolkits for both the FAST teams and the MOST teams, so that if any other counties in the state wanted to develop those teams, there would already be kind of, if you will, a map laid out for how to do that. Next slide. As we look at each of the sub-grants, Partnership Carson City, these were their funded goals. And as you can see, because they are subbing to other sub-awards, that's one of their goals. Number two, a lot of this is about jail diversion and deflection programs and using evidence-based practices, which the MOST and FAST teams do use. And then also to increase awareness and collaboration with community partners in service and to reduce recidivism overall. That's one of our goals through the FAST and MOST teams, is to reduce recidivism. Next slide. Community chest goals are pretty much the same, you can see here, but in addition, they are also providing naloxone added that in and have the drug take back days. I would highlight to you that while Partnership Carson City has a subs to those counties that I already outlined, Nye Community Coalition did take the responsibility for the naloxone distribution and the drug take back days. So they get all the funding for those, and then they push that money out to each of the coalitions throughout the state to provide access to naloxone and also for the drug take back days. I want to highlight, we are not, through the COSEP grant, paying for naloxone. That comes out of many other funded sources through the state, but rather are providing through the community coalitions some of the personnel, advertising, those sorts of things that go along with distribution of naloxone and also those drug take back days. So just to highlight that. Next slide. Nye Community Coalition, as I mentioned, they did not have a MOST or a FAST team in Nye or Lincoln, so they are working on establishing MOST and FAST teams in both of those counties. And then also, as we said, talking about the drug take back days and the naloxone distribution through the 10 statewide coalitions. And I would highlight with the MOST and FAST, in a couple of the counties, they have what they're calling a MOST light, because in our rural and frontier counties, they do not always have the same access to resources and personnel. So they may be employing the services more so of peer recovery support specialists and community health workers if they can't get law enforcement to go out, or if they do not have a behavioral health practitioner. They do not substitute that role, but they work under the direction of their law enforcement partners and their behavioral health professionals. Next slide. UNR, again, is funded out of this, and the overarching goal for UNR is to reduce recidivism using evidence-based practices and also to provide that evaluation. I will say that in the previous evaluation, we did have the practitioners, so the members of MOST and FAST, who were entering the data for the evaluation. So it becomes really hard when you're trying to do your job that is entailed under MOST and FAST, and then to provide that evaluation component. So a lot of it became a situation of, we received this many calls for service for MOST, we were able to go out on this many. So we wanted to get more of a quality of what difference these teams are making in the communities. And so one of the things that was funded under Partnership Carson City was a person to enter the data so that the practitioners wouldn't be the ones responsible for entering the data. So we can look more qualitatively at are these teams working? Are they doing what they're intended to do within our communities? Next slide. And then the last subaward that we have is SEI. And SEI is to provide, as I said, that training component. And already for this first year of our grant, which is really the second year of the grant, SEI has provided ORAS, which is Ohio Risk Assessment Screening training to our sub-awardees, and that is a screening tool that they use. You have to have a license to use it, and then anyone who uses it has to be trained to use it. So that's an example of the training that has been provided to the COSUP sub-award sites. Next slide. As you can see, our funding for the COSUP grant was just over 5.7 million over 3 years. Of that, to our sub-award sites, just about 5.1 million went out for that contract, which was SEI for the subject matter expertise training. They got just over 425,000. And then through the Attorney General's office, we received 230,000 of that grant for administrative types of purposes. Next slide. A further breakdown you can see on this partnership Carson City, who has the 4 sub sites there themselves, partnership Carson City, and then the 3 other ones. So they received the largest of the funding. It's just over $1 million, but under 1.1 million each year for 3 years to go to those 4 communities, primarily for Most and Fast. Another example that they pay for is travel to CIT, Critical Incident Team Training National Conference. So that's another example of how the funding is used for each of the teams. Community Chest, which covers Story County, as I mentioned, gets just over 83,000 for 3 years, for a total of 249,900,000 for 3 years. And then 9 Community Coalition received just over 1.3 million for 3 years, with about 440,000 per year. Next slide. For UNR, for the evaluation purposes, for 3 years, they will receive $100,000 to conduct that more qualitative assessment of how the programs are doing. And then again, SEI, who provides the training, it was just over 141,000 for 3 years. And then you can see the breakdown of the Attorney General's office's funding for the administration. And it does also pay for 1 administrative assistant for this grant. Next slide. What I did want to highlight is a couple of things going forward. The COSAP grant is doing a lot of great things on the heels of the Overdose Data Action Grant in those Most and Fast teams, basically on those counties that surround Washoe and then Nye and Lincoln County. There are some other counties that do have pre-arrest diversion and deflection teams, not necessarily Most and Fast. For example, Clark County at Las Vegas Metro, it's called the Lima team. So, and over in Henderson, they have the Mobile Critical Incident Team, so the MCID. So there are other types of diversion activities, not all called Most and Fast. But what we found is we don't have them in every county. So the Most or Fast Light, the Rural Behavioral Health Region, which is Humboldt, Pershing, Lander, Eureka, Elko, and White Pine, currently don't have these. I do have Humboldt highlighted because out of the alcohol and tobacco tax, they are trying to fund a MOST team in Humboldt. And then out of our Southern Behavioral Regional Health is Esmeralda and Monroe County don't have a MOST or Light. As well, we do not have these pre-arrest diversion and deflection teams 24/7 in each of our counties. So they are only covering specific hours and covering the calls that they can within those specific hours, or trying to expand their teams. And then also trying to work on having follow-up for the Most and Fast with the peer recovery support specialist and community health workers. We do have this in some places, but not in each of ours. And then also get that critical incident team training. Not all law enforcement have this training. I know, for example, that all new officers that go through Metros, Las Vegas Metros academy do get CIT training, but not all of our law enforcement agencies are getting it. So they become the behavioral health peace officers, which you can see is a component of the CIT training. So trying to get more officers CIT trained would be a goal that we would have. Next slide. Our recommendation would be to have these pre-arrest diversion and deflection and fast type of teams in all of our counties and expand our current capacity with our existing teams so that they can cover more days and more hours. And then additional funding for our follow-up teams of those peer recovery support specialists and community health workers. Additionally, that funding for CIT training for officers or behavioral health peace officers. And then also data sharing. We continue to struggle with data sharing between law enforcement and our public health entities. We're getting better. One of the things that we are working on as part of these toolkits is releases of information that would allow our FAST or most teams to have access to that information. These are all voluntary. They are not mandatory programs. So anyone who volunteers to accept the services of most and FAST, trying to get that release of information. That's how these differ in terms of, like, for example, the court, specialty court, where when someone's in court, they have to participate. Any participants of these are voluntary types of participation. And that would end my formal presentation to you, but I would welcome any questions that anyone has.
Thank you, Dr. Kerns. That was a really good presentation, and I have a couple of questions. The first one is, do you know if CIT training is being implemented in Washoe County?
I don't know if all of the officers are getting it in Washoe County. I can definitely follow up on that and find out. I know some are CIT trained, but I don't believe that all get it, but I will find out for sure.
All right. And I guess my question would be, is it at least being offered to all officers in Washoe County? I live in Carson County, so I recently had a check-in with one of the BOST team members in Carson, and they were letting me know that a majority of their law enforcement at the Carson City Sheriff's Office have been CIT trained, and the gap that they're seeing are the newer officers still need to enroll and attend that training. The second question that I had for you is in regards to Partnership Carson City and the distribution of funds. We had a really good presentation of what it looks like for a thorough and in-depth quality assurance evaluation and what the reporting guidelines are for the funds for Resilient Nevada. How do you feel about the evaluation measurements and quality assurance assessments that COSA has, specifically looking at the little over $1 million each year that is being distributed to PCC, being that we're a year into that?
Yeah, one part of this grant is that we do meet with, and I hate to use audit, but for lack of a better, do like an audit to make sure that they are spending in accordance with what's allowable under the grant. And then that's part of why too, the evaluation, we want to see if these programs are making a difference. So we do meet with them. We do have mandatory reporting requirements for both financial and for program evaluation, because everyone has a scope of work that they said they would do what they need to do. So that is all a part of it. And we do meet with each of the sub-awards regularly and go over those with them. So hopefully that answers your question in terms of the evaluation and the quality assurance.
All right. Now it sort of touches it. You know, when you say regularly, I guess I wonder what does regularly look like, but maybe in the future, because I noticed that UNR's cassette team is doing part of the evaluation. Is that accurate?
It's UNR, it's not CASAT. It's out of
Oh, it's
their
just UNR.
criminal. Yeah. It's Ronnie, it's more out of the criminal justice, the Grant Sawyer Center of Excellence, I think it's called.
Okay. And I know it's super limited, being that it's a handful of counties in Nevada that are using these funds, and that UNR would be uh participating in the evaluation of those funds and assessment of programs. But I would be interested to get some type of information from them to see what they found so far after year one. I have questions for you. I have a couple hands up or comments. I have Elise Monroy and then Dr. Wagner. Elise?
Can I just add one last thing before we go to Elisa's question? When you commented of some of the newer officers in Carson have not received CIT training, there's a couple of theories on officers going through CIT training. As I mentioned, I know Las Vegas Metro sends all of their officers through CIT training when they go through their academy. That's one philosophy, give it to everybody. But there's another philosophy that many of our practitioners who are involved in it with most and fast feel that, or mostly on the most side as opposed to fast, is that they would rather see the officers kind of get out there and get their feet under them with what their job is as a law enforcement officer, and then go back and take the CIT training later, because they can concentrate more on that CIT component because they know their job, as opposed to looking at 100 things they're trying to do as a new officer. So there are two schools of thought on that. So some of the law enforcement agencies don't send people to CIT until they've had some time on the streets. Elise, did you have a question?
Sorry about that. Thank you.
No, thanks, Terry. More of I think a comment. So I have to say, as the outgoing program manager of the OD2A grant, I'm really, really happy to see the work continuing through the COSIP grant. So that makes me really happy that you've been able to continue, expand, and improve a lot of what the subrecipients under OD2A had started. So that's, I feel like a win for what we tried to do from an OD2A perspective, which is capacity build. So one comment that I have, I guess, related to the development of, like, I think you called it most light teams. And I know that every community is going to have different resources and workforce capacity to support most. But I was on a 988 call yesterday, and NAMI National recently partnered with a polling group called Ipsos to do a national assessment of 988 like knowledge, like to see if people are aware of 988. It's a really good poll. I think everybody should look at the report, but there were 3 questions here that I think are relevant to the work that's happening here under the COSIP grant, related to a mental health responder responding to a crisis or a law enforcement responder responding to a crisis. And what this Ipsos poll found is that 85% of people nationally across the country believe that a mental health response is more appropriate than a law enforcement response in these situations, and that more people would be more inclined to call 988 and 911 if they knew that it was going to be a mental health response as opposed to a law enforcement response. And then there's some really interesting questions that look at like safety. So Black, Hispanic, or LGBTQ Americans are more likely to say they do not feel safe calling 911 for a mental health crisis, and many are afraid the police may hurt them or a loved one while responding to a mental health crisis. So I just kind of throw this out there as just a consideration, that while we're developing the mobile crisis teams, but also I think this applies to most, that it's important that there is a mental health response and that people will feel safer and more inclined to call if they can trust that it's a mental health responder that is going to be there. And I know that crisis calls are different than suspected overdose calls, but I think there's probably a lot of crossover. So just wanted to throw it out there.
Yeah, thank you for that, Elise. I have heard that as well too, that having law enforcement respond when someone's in crisis isn't necessarily always the best format, and rather have the your behavioral health practitioners to do that. I would love to see that information if I can get that from you, Elise.
Thank you, Elise. Thank you, Dr. Kerns, for your response. And yeah, I agree. The information is compelling, and it makes sense that folks who have been historically oppressed by law enforcement would feel safer if there was a mental health professional that was able to show up. And I understand the safety concerns, but I don't know that we have I mean, just in terms of what we're looking. Hopefully this is a future thing, because right now it seems like we don't have the infrastructure for behavioral health. But and that's what brings me to that whole two different lines of thought when it comes to CIT trained newer law enforcement officers. The faster, in my opinion, I'm of the opinion or the train of thought that the faster that law enforcement officers can be exposed to what CIT training brings, the safer those folks are. So in the interim of establishing that pathway to have a mental health professional show up to a 988 call, just giving law enforcement officers the information of what it looks like to deal with a behavioral health crisis rather than a regular call, I think is liable to save lives in the interim of that, establishing that behavioral health response. Our next hand is Dr. Wagner.
Hi, thank you, Carla Wagner. I had a question and maybe a request, Terry, and I think my question got answered. I wanted to know who at UNR was doing the evaluation. It sounds like Ronnie Dare's group through criminal justice. So that's great. And then I wanted to know, Terry, if you could share a little bit with this group, since you have the mic, about the Thursday's event, the SHIELD training. I know it's not directly related to these things, but could you just either now or at some point give an update to this group about that?
Sure. Chair Sanchez, do you mind if I respond to that?
Please, Dr. Kerns.
So in the southern part of the state, the Southern Nevada Opioid Advisory Committee does a yearly summit. It's the Substance Misuse and Overdose Prevention Summit. And as part of that, I think most of you are aware that months ago, Douglas County had an exposure of some of their personnel through the sheriff's office, a fentanyl exposure that ended up with some of them ending up having to go to the hospital. So we were getting a lot of questions and requests for training on officer safety, first responder safety when going and responding to fentanyl overdoses, any type of law enforcement action where in this particular case it was a seizure, and I think the powder got into the air and some people were exposed. So as part of that, through the SNOAC, Southern Nevada Opioid Advisory Committee, and then through CASAT and the state opioid response funds, we worked with, it's called SHIELD training, and it's an evidence-based practice, and it's kind of occupational health and safety for first responders. It's not just for law enforcement, but it's for first responders. So we are going to have that training. It's one of the there's different tracks as part of the summit. And we opened it up to law enforcement and first responders throughout the state. They were able to receive a scholarship to attend, and then through UNR, through CASAT, they paid for travel for officers or first responders to come to that. So the idea is people will become better, these first responders will become better educated on responding to not just fentanyl, but to these types of drugs, dangerous drugs. And also, when I say that too, it's not just safety, physical safety, but also mental health safety for officers. So we'll have a group that will go through that training this Thursday at the summit. And then as part of that, it'll become a train the trainer. And the idea is then those officers and first responders can train others within our community on these types of occupational health and safety types of issues for first responders.
Thank you, Terry. That was exactly what I was hoping you'd say. This is Carla Wagner again. And I asked Terry to bring it up because I had a look at the attendance list, and there's quite a few people going, but certainly not at this point, I think, representation from across the entire state in terms of first responders. And because they're setting up as a train the trainer model, the idea is to have this propagate. So if there are, can people reach out to you, Terry, or who's in charge of this if they want to make sure they get looped in?
It's Katerina Pulver from the health district, and I can provide that information with her information. I'll put it in the chat. One of the things that I would add is Carla is correct. We have a couple of officers from the northern part and one from the northeast part of the state that are going to it. But, you know, we want to build capacity. As you know, I think CASAT has been instrumental in naloxone distribution, but the capacity is exceeded by the demand. So because there's so many requests, that's part of the reason too we wanted to get this train the trainer out there so that law enforcement and first responders could also talk to other law enforcement and first responders and provide this, and the CASAT could be more directed toward the community providers for naloxone distribution.
Thank you, Dr. Wagner and Dr. Kerns. You know, I would say that the group that we have here is, you know, connected to the people that will see the expansion of programs, the addition of programs. And so I would just say that it's good to hear that the law enforcement and emergency responders are getting this training, the SHIELD training, but it sounds like it would also be appropriate for eventually peer support workers and community health workers to have an opportunity to attend these trainings, as well as hopefully through leveraging programs, they'll be able to respond to opioid overdose and situations that are similar. I have one more hand up for comment or question. It is Jamie Ross.
Thank you so much, Chair. Jamie Ross for the record. And I did just get confirmation from Kat Pulver, who is the overseer of the SHIELD training and the SMOP Summit. And there is still space for additional SHIELD participants. So if there is a first responder or a law enforcement officer who's interested in that, they can definitely be connected via Terry, but there is still space available. But only for the SHIELD training. Sadly, SMOPS is overbooked.
Thank you, Jamie.
Yes, thank you, Jamie. Do we have any more questions or comments for Dr. Kerns before we let her go? All right. Thank you again, Dr. Kerns. Super informational and very helpful. Any information that you would like to see or that was asked to be provided to the committee, please send an email to Garrett, as he is part of the administrative team that will be distributing information and posting our meeting minutes to our website after this. I do have a little side note as we move forward. We had some of the committee members join our meeting a little bit late. I just wanted to announce them as they entered the meeting after roll was called. We have Elise Monroy, as we heard her speak, Jamie Ross, which I mentioned, Brittany Collins Jefferson, and Carissa Loper are all in attendance. At this time, I'm going to move forward in the meeting and head to agenda item well, I would move to agenda item number 7, but I don't believe that Stephanie Cook is here. Let me check and see. Stephanie Cook, are you here? Did she make it? Okay, I know she was called away to the BOE meeting. And I just wanted to see if she was able to attend. If not, we will need to table this agenda item to the next meeting. I don't hear Stephanie Cook, so we're gonna move to we're gonna table agenda item number 7, and we will hear from her in the future. And we will move to agenda item number 8, which is ACRN membership team commit or term committee member terms, commitments and expirations. And this is informational. I just wanted to give a heads up to the committee members and remind the members that the terms are set to expire at the end of the month in September. If you have not reached out to Garrett, please do so to continue your term. Currently, we have almost everyone's response, and thankfully, gratefully, most folks are going to continue with the ACRN committee. And that'll set us on schedule for eligibility and membership of this committee until 2025 when it comes up again. Do you have any questions or comments as far as it comes to terms for the ACRN? All right, I don't see any hands up. I am going to now move to agenda item number 9, which is public comment number 2. Public comment will be taken during this agenda item regarding any item appearing on the agenda. To provide public comment telephonically, dial 775-321-6111. And when prompted to provide meeting ID, you can enter 137-487-683#. And keep in mind, if we do have anybody for public comment, to be considerate of others who may wish to provide public comment, and please avoid repetition. Limit your comments to no more than 3 minutes. And remember that no action may be taken on a matter discussed under this item. Do we have anybody available or interested in public comment number 2? Garrett, do you see anybody?
I do not.
Okay, I'm gonna give it just a couple of seconds here to see if and confirm that we're not missing anybody. I do not see anybody interested or available for public comment number 2. And at this time, we will move to agenda item number 10, and we will adjourn this meeting. Thank you, everyone, for attending. Thank you for presenters for showing up and giving us some much needed and valuable information. We will send out the schedule for our next meeting here in the next week or so. Thank you, everyone, for your attendance. Have a great day.